Good afternoon, everyone. My talk today will be focused on AmpC producing organisms from Enterobacterales. So this is just a quick outline of the talk. I can talk about categories of AmpC, betalactamase resistance mechanisms, and the mechanism of resistance and the different methods of detections that are available, and some guidance and guidelines that I have consulted. So AmpCs are class C serine betalactamases, which are enzymes that can inactivate betalactam antibiotics. And example where this might be important and pose a dilemma is, for instance, Enterobacter cloacae is isolated from your patient and it is susceptible to keftraxone, and the patient is placed on keftraxone, and you find the MIC increases and can no longer be considered as susceptible to that agent. A few acronyms have been used to represent these organisms, which may produce AmpCs, such as ESHCM, SPICE, and SPACE. So for instance, SPICE, S for Serratia, P for Providentia or Pseudomonas, indole positive Proteus species in I, and Citrobacter in C, and Enterobacter for E. AmpCs can be produced by a variety of Enterobacterales organisms and by one of three mechanisms. So firstly, can be inducible resistance through chromosomally encoded AmpC genes. So that can be demonstrated in Enterobacter cloacae, Serratia marcescens, Citrobacter frondii. And the second mechanism is where it's non-inducible chromosomal resistance, or also known as stable de-repression due to mutations in AmpC regulatory genes. So for example, in E. coli, Shigella species. And thirdly, through plasmid-mediated resistance that can be commonly found in E. coli and Klebsiella pneumoniae or Salmonella species. So in the non-inducible chromosomal resistance, the second category, and the third, the gene is there. In the non-inducible mechanism, a promoter or attenuator mutation has been turned on in the bacterial DNA that causes the gene to always be expressed, and the enzyme is always there. In the third category, the AmpC is also always being produced, and this can result in where testing the organism, it will always test resistant. And with depression organisms, the inducible category, it's much trickier because they will test susceptibly initially, and there's a potential that this isolate will become resistant after exposure to betalactam antibiotics. And normally, the negative regulatory protein AmpR reduces AmpC betalactamase expression to very low levels. Another recycling protein known as AmpD cleaves the residues from cell wall degradation products and allows them back into cell wall synthesis pathway. And also at the same time, it reduces the ability to bind to AmpR. When it's induced, so when certain antibiotics, betalactams, induce the production of cell wall degradation products, these degradation products compete with something called UDP for binding to AmpR. And the decreased UDP binding to AmpR leads to increased production of AmpC enzymes. And as the concentration of these degradation product increases, AmpD, the recycling protein, is overwhelmed and is unable to cleave all the peptides, and leading to binding of these uncleaved products to AmpR, and subsequently there's increased AmpC transcription. But in these instances, after beta-lactam exposure ceases, AmpC production levels can generally return to baseline. But in cases of stable de-repression, if there's a mutation which occurs in the regulatory genes, the de-repression can continue and resulting in overtranscription of AmpC and even in the absence of a betalactam trigger. So there are various methods that have been described for AmpC detection. And firstly is the use of AmpC inhibitors such as cloxacillin or boronic acid, and their specificity is in the range of 70 to 90% as quoted in the literature. There are also some phenotypic assays, but the limitation of these are they are unable to distinguish between AmpC production due to de-repression of a chromosomal gene or whether there's a presence of a plasmid associated AmpC gene. There are also molecular approaches, but they are limited to research settings. And there are also no currently endorsed criteria from CLSI. And actually the most common method which we use in the laboratory is by looking at the antimicrobial susceptibility test pattern and looking at the anticipated susceptibility patterns. So I'm going to go through one of the recently published guidance documents that from ITSA that was developed by a small team of experts that address questions regarding treatment based on the review of literature and clinical experience and expert opinion. And these guidance are US-centric, and the suggestions are based on drug availability and epidemiology. But there are things that are globally applicable, and I find the rationale for their guidance to be informative. But every patient is different, so deviation will be necessary and is open for interpretation. So the first question which they addressed is which Enterobacterialis should be considered at moderate to high risk for AmpC production and induction. And with the current acronyms used to represent these organisms, so for example, SPICE, there's risk of undercalling and overcalling the risk amongst these species. So, for instance, Citrobacter frondii is known to harbor chromosomal AmpC genes, but Citrobacter kozeri does not. So there are differences within genera. And with indel positive Proteus currently refers to Proteus vulgaris and penneri, but they don't contain chromosomal AmpC genes. So available data on the risk of AmpC induction across bacterial species are from observational studies. And they focus on Enterobacter cloacae, Klebsiella aerogenes, and Citrobacter frondii. Klebsiella was renamed from Enterobacter aerogenes. And in vitro data and clinical reports that 8 to 40% of these isolates test susceptible to keftraxone, they might become resistant within a few days of exposure. So therefore, these organisms that are, if they are recovered in culture, other than those recovered from uncomplicated cystitis, the guidance suggests to avoid treatment with keftraxone or ceftazidime, even if isolate tests susceptible to these agents initially. In contrast, Serratia, Morganella, and Providensis species, the likelihood of significantly expressed AmpC in these clinical isolates is less than 5%. So despite inclusion in many mnemonics, the risk is low. And the ITSA panel suggests that this, to select an antibiotic based on antibiotic susceptibility testing results. So giving keftraxone if these organisms test susceptible. Some less encountered organisms such as Hafnia alveoli, Citrobacter youngae, and Yersinia enterocolitica do carry inducible chromosomal AmpC genes, but there's not much data available regarding them. And For the low-risk organisms and less commonly recovered ones, in cases where there's a high bacterial burden and where there's limited source control, for example, in infective endocarditis, they suggest that to consider Kefir instead of keftraxone, even if the organism test is susceptible. And I just came across a different acronym that may be helpful in remembering which are moderate to high risk. So the acronym is HEC-YES, and H for Hafnia, well, even though it's less commonly recovered, E for Enterobacter, C for Citrobacter, and K for Klebsiella aerogenes, and Y for Yersinia. The second aspect which was considered was which features should be considered when selecting for antibiotics. And the table here shows that the beta-lactam antibiotics fall within a spectrum of the potential for inducing AmpC. So the aminopenicillins and the first generation cephalosporins and kefamycins are potent AmpC inducers. And in moderate to high risk organisms for AmpC production, these antibiotics are hydrolyzed, even at basal AmpC levels. So they will test non-susceptible and not pose as much of a treatment dilemma. With imipenem, it's also a potent inducer, but it is stable against hydrolysis. And there's the induction potential of ertapenem and meropenem has not been formally studied, but they are usually stable. With Peptas, even with the addition of tazobactam, keftraxone and aztreonam, they are weak inducers, but they have the potential to be hydrolyzed. On the other hand, Kefir has the advantage of both being a weak inducer and can withstand hydrolysis. And they go on to look at the role of Kefir in treatment of these infections. And they suggest that organisms with moderate to high risk of AmpC production, where the MIC is less than 2, you can consider using Kefir. They say in the literature, there's been case reports of failure, but it has been dosed every 12 hourly. And in those studies, the co-production of ESBL was really investigated. And there has been the presence of some outer porin mutations that were identified in some reports. And unfortunately, randomized controlled trials that compare the clinical outcomes in patients who receive Kefir versus those on carbapenem is not available. There are some observational studies that suggest similar outcomes, and there has been meta-analysis of 7 studies where Kefir was looked at versus carbapenems for Enterobacter species, Citrobacter species, and Serratia species in bloodstream infections. And there's been no difference in clinical outcome, but there's heterogeneity exists amongst these studies. And so it's difficult to interpret. However, there's been no clear clinical failure signal. In the guidance, they suggest that with Enterobacterales that have Kefir MICs of 4 to 8 elect to go with a carbapenem as treatment because there's higher likelihood of producing ESBL. And in one study where 10 out of 217 who were given Kefir that had isolates that had elevated MIC and were ESBL producers, they had died. And in looking at the role of keftraxone for AmpC, the available data indicate that there's a significant risk for the emergence of resistance when keftraxone is used. And they suggest to generally avoid keftraxone. But in the cases of uncomplicated cystitis, because it is a mild nature and there's urinary excretion of keftraxone, keftraxone may be adequate. However, there are some challenges in interpreting studies on how frequent resistance emerges with keftraxone treatment in the organisms that have moderate to high risk for AmpC production. Because for some of the challenges include there are no endorsed CLSI criteria, so whether it has been accurately detected in these studies, and whether these organisms that were non-susceptible for other reasons. For example, they produce ESBL, betalactamases, or these studies, when they looked at, they combined the estimates of low-risk organisms with ones that posed higher risk. So there are various challenges in terms of the interpretation. And in terms of the role of Peptas in the treatment, it is mentioned that tazobactam is less effective at inhibiting AmpC than the newer betalactamase inhibitors, such as avibactam, rilibactam, and barbobactam. And the role of Peptas remains uncertain. And there was a meta-analysis published in 2019 that showed that there was no difference in mortality when Peptas was looked at versus carbapenems in the treatment of bacteremia in Enterobacter, Citrobacter, and Serratia species. But again, there's heterogeneity across the studies, and there are confounding factors as well. The best current available data is from Merino-2, a trial that is a pilot unblinded trial that compared outcomes in 72 patients with bloodstream infections that was caused by Enterobacter, Klebsiella aerogenes, Citrobacter, Forndii, Morganella morganii, Providentia species, and Serratia species. And Peptas was given as a standard infusion versus meropenem 1 gram 8 hourly, also as a standard infusion. And there were no significant difference in the primary outcome, which was a composite outcome that included 30-day mortality, clinical failure, microbiological failure, or microbiological relapse. There are, however, some conflicting findings seen between the different components of the composite outcome. For example, there were numerically more microbiological relapses in the meropenem group, and there were the patients that received meropenem were older and had more community-associated infections. And but it was noted that in the study that infections due to Enterobacter species achieved the primary outcome more than those who were not infected with Enterobacter species. However, a larger randomized control trial is still needed. And there are two observational studies that also identified increased mortality with Peptas treatment, and therefore this guidance suggests caution in giving Peptas for serious infections. But it is a reasonable option for mild infections, such as uncomplicated cystitis. And it also speaks about the role of the new betalactam and betalactam inhibitors. And it is suggested to reserve these agents for organisms that exhibit carbapenem resistance. And with Keftas, Avibactam, imipenem, relebactam, and meropenem verbobactam. These have excellent in vitro activity and clinical outcomes that show their effectiveness. And cevidericol also demonstrates in vitro activity. But with ceftolozane tazobactam, it was not suggested. Ceftolozane was initially developed against Pseudomonas-derived AmpC cephalosporinase, but they said less is known about its activity against Enterobacterales that produce AmpC. There is reasonable activity that was seen in a study that looked at in vitro data, but it only showed activity against 19% of Enterobacter cloacae isolates. And together with these considerations and concerns that tazobactam have decreased inhibition, led them to not suggest its use. What is the role of non-betalactams? So with cotrimoxazole or fluoroquinolones for non-UTI, they have not been formally evaluated. However, they are not substrates for AmpC hydrolysis. And they suggested that for step down for bloodstream infection, cotrimoxazole or fluoroquinolones are reasonable oral step-down options. However, they don't advise nitrofurantoin, fosfomycin, doxycycline, or carmoxyclav, as they achieve poor, unreliable serum concentrations when used to treat AmpC-producing Enterobacterales. And they also suggest to limit fosfomycin used for E. coli cystitis, as there may be a FOS8 gene that is present that are intrinsic to other gram-negative organisms, including those organisms that are at moderate to high risk for AmpC production, where they can hydrolyze the drug and lead to clinical failure. So I also had a look at the ICMID guidelines for the treatment of infections that are caused by a multi-drug resistant gram-negative bacteria. And they use a category of third generation cephalosporin resistant Enterobacterales, which I guess includes both AmpC Enterobacterales and ESBL organisms. And under this umbrella term, they recommend a carbapenem for bloodstream infections and severe infections. And for low risk and non-severe infections, this guideline recommends Peptas or carmoxyclav or quinolones. Here I have a table which is not published, but is still under discussion. And this is a table that Prof. Brunk had given me for reference. And this is produced here for discussion purposes. And just looking at the different treatment options that are available for these organisms as well, that can be potentially be placed in the next best practice guidelines for the newer agents. And in conclusion, these organisms that are of risk of AmpC productions are important in antibiotic selection decisions, and better diagnostics are needed to pick them up. And a lot of the data are still from observational studies, and better designed, adequately powered interventional studies are required to quantify the risk of which organisms and what the danger that they pose, and which are higher risk versus lower risk, and also looking at the role of the different antibiotics, so such as Peptas, Kefir, and other agents. And the newly published ITSA guidance is based on informed suggestions rather than recommendations. And yeah, so thank you for your attention, and I would like to just open the floor to discussion.
Thanks very much, Edward. Can you don't stop sharing your screen at the moment? If you could go back to your table, please.
Okay.
Thanks very much. So thank you for a very comprehensive look at AmpCs. And I wonder, Adrian, as this is your table, whether you would like to make comment on this table. We don't have a lot of time, but if you could make some comment and share your ideas on this for the spice Enterobacterales.
Thank you, Mark. I'll keep it short. First of all, I'd like to also commend Edward for tackling a very complicated topic. I think his in-depth knowledge will do him well in the upcoming FCPath exam. He clearly understands AmpC. Secondly, the problem is that you can't diagnose it. There's no guidance internationally in how to identify it. So you've got to assume from high-risk bugs such as Enterobacter and Citrobacter and so on. There are very, very, very few properly conducted clinical trials. All of it is observational. So regarding pyelonephritis, I've already moved aminoglycosides across as preferred treatment rather than keep it as alternative treatment. I can't use the pointer. Otherwise, for the Enterobacterales, I think that there is evidence of in vitro activity in spice for Kefir tazobactam. We're trying to restrict it basically for Pseudomonas that produces AmpC, which overall will have in this country a very low activity. I don't see a big role whatsoever for Kefir in South Africa at all. For Pseudomonas, 70% of them are up to 70% produce a betalactamase such as Vim, and therefore Kefir is resistant. We did not want to put the other new betalactamase inhibitor combination, Ceftaz-Avi, here, because it also has ESBL activities. So then you replace, for clinicians without stewardship interventions, replace meropenem with Ceftaz-Avi, and then they use it for all of them. What I like about the European guideline, particularly, finally, Mark, is that when I emailed Misak Paul in Tel Aviv and I said, why don't you include AmpC? And he said, it's too complicated. The European Society that decided against it. The other problem is that many of these bugs that do have AmpC, inducible or plasmid and so on, are also ESBL positive. That is in a nutshell, Mark. Any other questions?
No, that's great. I think Sean has a question. Sean?
Yeah, thanks. So, yeah, thanks, Edward. Very comprehensive and detailed. So, as a takeaway message, would you then recommend Kefir or a carbapenem for serious infections with Enterobacter, so bloodstream infections? That's the first part of the question. And the second part is, I still am a little bit uncertain about the role of tazobactam for Enterobacter. I mean, is it not to be used even if the MIC is low? Thanks.
For the first question regarding Kefir, so if the organism is at high risk, so moderate to high risk of AmpC production, and the Kefir MIC is low, then I think Kefir is reasonable. But with serious infections, yeah, especially if it's empiric, then I think I would go with the carbapenem. And second question was regarding Peptas. With these organisms, so I think based on the current evidence, even with the randomized control trial, the question is not definitively answered, and we still need more studies and data regarding that. But based on that tazobactam's activity is less effective, so it is not suggested when there are other agents. So if kefir is available, then would go with kefir rather.
Okay, great. So Edward, if you could stop sharing the screen, and perhaps Adrian, just the last comment.
Yeah, I think Sean nailed it. It's really, really difficult. And Edward's answer. I think, in my opinion, we need to focus on the bug. The highest risk is Enterobacter. Amanda Overmeyer is doing an MEd on Serratia. They've done the whole genome sequencing, and I reviewed her paper. There isn't a single isolate that actually produces AmpC. So when you deal with an Enterobacter, the sicker the patient is, the more I personally would err towards a carbapenem. Anything else, I'm happy if you use either one of the two, but then the lab's got to provide you with an MIC. Thanks, Mark.
That's helpful. Thank you.
So thanks. Yeah. So thanks.